pleasure to send this message for this launch, and would like to start by saying big thank you to the ACCEND Project team that is represented by both ADRA and Oxfam. From EU side, I just wanted to say that rural development is a key priority of our cooperation with Sri Lanka. For nearly a decade, we are providing different programs in order to support both government and local communities to tackle the issues, not only rural development, but also many cross-cutting areas. So gender is really one of the priority at the heart of the EU cooperation in the country. So we have several programs, but integrated rural development program is one key and important program. So this ACCEND project under IRDP is one of the 5 projects currently ongoing in Uva and Central provinces. For past 4 years, we are working together to achieve the expected project outcomes and the study findings of health and life experiences in the Ambagamuwa DS division is one of many endeavors with the project's sectoral focuses on gender equality. So I hope this study will contribute towards the important discourse of gender-based violence in Sri Lanka and in turn contribute towards upward progression of the Sri Lankan society. So I'm very happy to mention that you could manage to launch this study at least virtually today under COVID-19 pandemic situation at this current moment. So, as the EU program manager of this project, I wish you good luck and I hope you will have a very productive session ahead today. So once again, thank you very much for inviting me.
Hi, I'm Taria Markek, Programs Officer for ADRA UK, and it's my pleasure to introduce you to the virtual launch of the HLEAD study today. ADRA UK has been privileged to implement the Assisting Communities in Creating Environmental and Nutritional Development project, also known as ACCEND, together with ADRA Sri Lanka, Oxfam Italy, and Oxfam in Sri Lanka. ACCEND is funded by the European Union and is being implemented in collaboration with the Government of Sri Lanka. This 4-year project is currently in its last year and has been contributing towards improving health, nutrition, hygiene and sanitation in the rural and estate communities of the Uva and Central provinces. Specifically, ACCEND targets communities in 30 estate divisions in the Nuwara Elia and 22 rural communities in the Martale and Monaragala districts. The main outcome of the project is to strengthen communities and public institutions towards an integrated, mutually accountable service delivery system in the wash and health sectors. This will be achieved through 2 main approaches. Firstly, vulnerable rural and estate communities will have increased access to wash facilities, improved personal hygiene and sanitation practices, and community-driven services managed in collaboration with strengthened public authorities. The second is through the improvement of health and nutritional status within the estate and rural communities through increased access to proper healthcare, knowledge, and practices. Gender is also a strong component of the project, and it is under this broad sector that the project mobilised support towards the revitalisation of the Mithra Piazza desk in the Dukoya Hospital, and conducted a study to map gender-based violence in the estate sector. The study, titled the Health and Life Experiences Study, carried out in the Ambagamuwa division, is one of the strategic attempts of the project to contribute towards bringing attention to issues faced by communities in this division. By disseminating these findings, we hope to contribute towards forward planning of relevant stakeholders and to create a discourse that will contribute towards positive results in the long term. I finally thank the EU delegation in Sri Lanka, who has been providing support to our teams that work in the field. I hope you will find the presentation informative and useful in your work.
The apex or nodal agency in the Ministry of Health, which is responsible for maternal and child health, including women's health. In other words, we are responsible at national level for the Ministry of Health for family health. So that is inclusive of gender and women's health. There is a special unit called Gender and Women's Health Unit, and our unit is responsible for gender and women's health, so which is inclusive again of responding to gender-based violence. So health sector response to gender-based violence is one of our main components in our agenda. PSA is a gender-based care center for survivors of gender-based violence, and this is situated or located in a hospital, mainly at the outpatient department of the hospital. And the service providers are a medical officer and a nursing officer. Service they provide is provision of emotional support. That is, when a survivor comes, they do active listening and they try to provide emotional support to the survivor. The survivor could just come walking in. They don't have any barriers, because normally we know to come to a hospital, to come to a clinic, sometimes you need a referral, a formal referral. But here, to our Mithuru PSS centers, they don't need any formal referral. Any person can walk into the center, or they can be referred from the OPD, from any clinic in the hospital, from any ward or any unit in the hospital, or from outside service providers. Again, I'm stressing that these referrals are not formal referrals, should not be. They can just refer them. Sometimes they have to refer within the hospital as well. Like, so if they want care of the psychiatrist or the JMO, maybe the surgeon, so within the hospital they refer to the relevant unit, or outside the hospital also. That connection is emotional support, and the referrals, as I said, within the hospital and outside the hospital, and the follow-up. So when we do that, sometimes we go beyond, like now when we refer for social services, then sometimes we will have to assist them in achieving something, maybe minor credits or something, or some self-help. Our ultimate objective is to have such a center in all the hospitals where there is specialized care. So in our country, the specialized care is provided up to base hospital B level. So we have about 110 hospitals in the country which have specialized care. So our target is to have a center in all these hospitals. But up to now, we have 76 such centers in the country, covering all the districts. They have to identify the survivors and attend to them and refer them to the Mithuru PSS centers. On the other hand, they have to address the gender stereotyping. Where you see gender stereotyping happening, to tell them about this, explain them, and whenever there is a good male participation, appreciate it, so that take them as role models, so that the community would try to change it. And also in each stage of the life cycle, this matter should be addressed. the gender stereotyping, the negative norms, the toxic norms. So these things are now we are in the process of mainstreaming the reproductive health components of our family health bureau, so that in each stage of the life cycle, now like for an instance, in the maybe in the preschool age, right, during preschool days, they have to know how to care for each other, how to tolerate the others, how to respect, caring, sharing, respecting everything. They can learn from there onwards. In the schools, how to behave, how to respect, how to share the things. So these things in each stage of the life cycle, if we slowly try to inculcate these good norms into the normal behavior of our population, our people, then we might be able to achieve some results. Otherwise, it's not that easy. But yes, we have started doing it and we are doing it, but we won't achieve results overnight.
Community itself is changing. It is an evolving phase of the community, and some of the people who have been working are not working anymore. The younger generation is not there, so that aspect of it needs to be considered and taken into account. It was planned long ago for estate community will not work in the present context. Third thing that we noticed was relative to the, I'm talking more or less like relative to the rest of the country, or what is unique in this community, was that still the husband's power grip, or whatever you call it, is fairly strong in this community, and that is one of the reasons for some of the findings about violence and other things, the use of their funds, use of their salary, all that is still that is little more. So particularly the people who who is not used to this community should take this kind of findings for consideration. I think again another thing is that this SRH knowledge is lacking in this community relative to the rest of the country, and also the attitudes are lit as less liberal or less modern than the rest of the country. So the estate management seems to be fairly prescriptive kind of thing when it comes to their support and sort of towards disciplining that kind of thing, rather than taking them on board for some of the activities and trainings and things like that will help in balancing these deficiencies or gaps in this area. I think they were the kind of things that I have noticed. Also, I think the health system support for the community, that is the community health support in this area, if there seems to be some kind of a two-pronged approach. I think the government staff is supporting. There's an intermediate group supporting from the estate medical practitioner, the other officers that support. These two groups should come together, and they should work together, and they should have more close relationship between these two groups. I think that will be what is a deficiency now, or what is a negative thing now, can be converted into a very positive thing if own minds. I think that in the sense that we, including myself, had doubts whether it is really, whether we'll find it difficult to approach these people when it is sort of a sensitive subject, it's a worrying thing, whether it will be a problem, whether that kind of thing. It didn't materialize. So I think our attitude towards research in this area should take these findings and the participation component as a very positive thing, and that the problem that we anticipated didn't materialize. Maybe a few problems, challenges. I think the main challenge. I mean, so I think I'm mentioning this as a very positive, on a very positive note, that though we were worried about conducting this study, we didn't have have issues that we worried about. The main challenge is was the coordination, or rather getting the formal approval from the authorities, because we had to deal with the state authorities and also with the state authorities. So that kind of formalities were an issue at the beginning. But of course, with the help of staff of ADRA and other people, all those things were sorted out very nicely. So ultimately, we proceeded. Of course, we had a little bit of difficulties with difficulty in interviewing because the husband was at home or things like. I don't like to say it has failed, but it has nearly failed as far as I'm concerned, because the recent effort of getting a very good book into the schools failed about a year ago. How to reach these girls? I think the estate sector has a very good organization, or rather tools to reach these people. One is the estate midwife, health worker. Then there are other people, and the state health officers like the PHM, who can collaborate and talk to these people. And they are mostly women, or all are women, and they can do targeted activities for the people who are younger, people who are 10 years, 11 years, who are likely to come into this. I think you can get the mothers to join in these things, so that then the mothers will understand talking about this is normal, this is good, and that taboo or whatever that is will go, and possibly for the next girl in that family, the mother herself will do. So I think community participation, along with organized and given leadership by the public health midwives from the state sector, plus the estate medical personnel who are working, and possibly supported if necessary by the MOH or the EMA. I think that kind of program is what will work. So I think it is again comes back how you target your education, sexual and reproductive health education to this community, which covers both men and women. Law kind of thing is more ingrained into this society. There's no debate on that from some of the comments that they made. Some of the comments they spoke about violence, engagement of males in family planning. I think this is not unique to this community or this sector. Even in the rest of the country, they may not be that involved. As far as the first pregnancy is concerned, I think it is rather quite a number of couples would be sort of looking forward, at least their in-laws will be looking forward to having a pregnancy, so that may not be significant. But even the second one is pretty low. Second one is the one you need to space, and that is where the problem is. And also, I think, I don't have the figures as such, but I think cross-analysis at some point shows that the family planning is linked to violence. So there is a certain group of people who base violence on family planning, either mostly for the use of family planning, or they prevent family planning. So the male involvement in this kind of decision making needs to be promoted, needs to be encouraged, needs to be tradition because what we are used to kind of thing is the thing that is working there. People are used to sort of taking into a fact that pregnancy is some other's business, caring is her business. Our thing is to support her. You know, that is the general traditional way of looking at it. Women go through the formal kind of work, plus then they have to do the informal work, which is as much as or worse than the other one, particularly in the estate community where all the resources are not available as in an urban community, so they'll have to do more work than that. Possibly they have more children also to care for, and even the elderly tend to be caring for the younger children. So the workload for these people is very much more. And on top of that, that seems to affect the health of these people, because when you ask some of the questions, I think the report comes out and tells whether you are okay, like they will say okay. But when you ask specific questions about did you go to see a doctor in the last couple of weeks, or did you have a headache for the last something. So I think that shows that they are not as healthy as they think they are. So I think that finding out of this report is very important, because this is subsequently you will realize that this is worse among the women who have violence, who experience violence. We can take it up with the management and take this further. From the colonial days, I think the standards have not changed much. Necessary requirement that they are trying to fulfill is to give accommodation. Whether it should be a healthy accommodation, whether it should be a suitable accommodation is not included in that. Any person would know that one room for the whole family does not give any chance for privacy. But they have to live, they have to eat, they have to drink, they have to have their sexual relationships, they have to have children, their children has to be sleep. All that happens in one room. I think nearly 40% of the people said they live in one room. I can't remember the exact figure. Gender mainstreamed, so that this kind of thing will be recognized in the planning stage of the project or the program that you are doing in the estate sector. I think this is very important in this community relative to the rest of the community. So what programs that you plan for them, they should be gender mainstreamed, so that they will look at the program